Well, good morning, everyone. It's an honor to be here, to be on this platform and share our story. I'm Augustine Amusu, CIO, Mediclinic, Middle East. And in the last couple of weeks, I must say, it's been quite a lot of travel for me. I'm home in Dubai. Went to Cape Town. From Cape Town, I went to Milan. From Milan, I went to Spain, Munich, and then here. So, and along the way, I use it as a period of reflection as well. Just reflect on my experience, and also you can't help but benchmark and compare your experiences across the way, how people interact on various health systems. And I must say, it did make me realize that it's a pleasure to actually be resident in the UAE and everything that we experience there, specifically from the level of digital adoption, the skills that are available, and of course the leadership that's available there, to put it all in context. So who are we? Mediclinic in the Middle East. We're roughly around 40 plus operating units. We operate what I would call a complete healthcare system. What do I mean by that? We run inpatient, outpatient, daycare surgical centers, pharmacy, radiology, laboratory. We have home care business, essentially the complete chain itself. And it is a pleasure working in that context and all of the challenges that we see. We have roughly shy of 8,000 employees across the piece. Now, like in all of your markets, one of the things that we see in the UAE is that care is gradually moving outside of a traditional hospital setting. What you would normally do as an inpatient stay, you're generally doing that as daycare surgical procedures, gradually moving to outpatient and essentially moving towards the home. And this is happening in all of our markets. The rate of change is different. It's faster in others, slower in others, but actually that's where it's accelerating to. So what we've decided as an organization to do is put ourselves in various parts of the value chain, essentially to be able to remain relevant to the patients going forward. I'll come back to this point later on in my presentation. And what is driving this? Some of the things that we see is as a result of better drugs, the Ozempics of this world, many of you know it, better surgical technologies overall, and some of it essentially down to regulatory changes. But essentially that train or that drive can't be reversed. It's heading clearly in that direction. So in 2018, we started the rollout of our electronic health record system. But I'm not here to tell you about EHRs today, because as far as I'm concerned, they're foundational. They're a ticket to the game. If you want to exploit many of the things we talked about over the last day or two, you must have them as a bedrock to be able to exploit many of those things. And in actual fact, what we know, many of you who've been through this project, the implementation only starts when the project is completed. And I remind myself, and I tell my leadership that every time, the implementation only starts when the project is completed. So this goal for endless refinement and trying to ensure that we can benefit and get as much as we put into the solution, and so that we can get to a better degree of productivity as an organization. So in our context, we had to keep driving. In 2021, we finished that implementation, and we had to start driving various degree of productivity through the system. In the end, that's why we bought the system, to be productive. Realizing the business case, clinical productivity so that our clinicians can get everything that they want to derive out of the system, outpatient patient experience, and of course, in the end, for everything that you do, you have to be paid for it. So revenue cycle productivity. All of you will know in your markets that that's a very tough challenge to ensure that your systems don't essentially end up being a burden to the clinicians because you want to drive a better revenue cycle regime through. At the heart of what was of concern to us at the start of this journey was essentially solving the access conundrum. You know, although your services are generally available, it doesn't mean they're available for all. So for us, it was important that we ensure that irrespective of your disability, your location, or your preferences, you could access our organization whenever you wanted to. So we went through what most of you will know today, ensure that booking was available, virtual consultations. We had a care coordination center. We did pharmacy home deliveries. We went through COVID with most of these things as well. And with that, we launched a booking solution, essentially gives you the things I mentioned earlier on, the ability to search for a clinician, discover them, discover their location. Do you want a virtual consultation? Do you want an in-person consultation? And then all of these preferences, Q&A that ensures that we pair the right doctor to the right patient. Again, trying to ensure that the preferences that they have, that we can serve them along that. To derive a better degree of productivity in the organization, we turned to our colleagues at InterSystems as well and tried many, many use cases using AI, either in the machine learning front or Gen AI that we've just started that conversation more recently. Now, on the ML front, what you typically have, and just to give you an example of the model itself, we curated certain data sets in our organization, took that through the model, did certain validation with our teams internally, but the most important thing for us is embedding that in the clinician workflow, ensuring that the clinicians can get certain triggers or feedback in the system depending on what we're trying to achieve. And one example was trying to determine the risk of unplanned readmission. So as the patient gets discharged, clinician gets a notification, but just not any odd notification, a notification that says, this patient is at risk of being readmitted for these certain reasons. And then, of course, the clinician can decide what they want to do from there. Stay one more day in the hospital, come see me at my outpatient surgical center the following day. And this loop, as it's been discussed over the last few days, just ensuring that you continue to train the model and have better data sets and derive better outcomes is, for us, is what would really make this sort of technology, machine learning, deriving that to their workflow, much more useful for them as they go along in their journey. Other things that we're looking at with our colleagues and internally and with InterSystems, I mentioned around unplanned readmission risk. We're also looking at no-show prediction. This is a problem in every market. Patients book, don't turn up. It's a lost opportunity for the doctor, lost opportunity for the organization, and then we have to, of course, rebook for patients as well. So we're looking at that. And on the Gen AI front, we're really excited about this. You've heard many stories over the last day or two. One, being able to use it to summarize notes for the doctors. I mean, the systems that we put in front of our clinicians today, to be fair, that's not what they would actually like to use longer term. They want to be a bit more smarter in the way they interact with patients and let the technology not be a barrier. But of course, using ambient AI as well to take the output out of the conversations between the doctors and the patient, and then parking that in the EHR for the doctor to review and then sign off. This is where they really want us to be, and that's a journey that we've started on more recently, and we're hoping to deliver them some use cases. Again, to derive further productivity out of our systems, we also decided to extend into health share, essentially running our own internal HIE. And what was our goal for that? We wanted to, as I said earlier on, care is gradually moving outside of the traditional hospital setting. And if you want to be able to have a line of sight across data in all of those settings, this is some of the things that you have to do. So essentially, our plan is to have an enterprise master patient index. So rather than having your MPI in your EHR, you take it one level above, and what you can then do there is you can consolidate both track care or EHR data and non-EHR data, and then have a longitudinal view of patient records across the piece. So we established an EMPI, we're consolidating data across multiple areas, and ultimately giving us the opportunity to start to define certain AI standards and exploit things in that particular domain going forward. Now, clearly, we're doing lots of investments, so I'm sure I must have a big pocket. We're investing also in health insight alongside health share. And the story here, particularly for us, is, are you asking your system, who's asking your system the question, are you asking your systems all the questions you should be asking? So the questions that you don't ask, you don't get the answer for, but could you have a system that essentially asks those questions that you're not asking? So we're currently implementing that. The goal for us for here is nicely aligned with our track care data set. And of course, in the end, it's going to give us real-time actionable insights into our data. But what's more interesting for us is that it means that we can actually modify the cubes ourselves to get more data, and again, keep modifying until we get to where we're trying to actually get to. So we're excited about this, and in a couple of months, we should see that become a reality for us. Certain use cases are available to you when you implement Health Insight. On one side, you could do certain wellness model. So of course, identifying care gaps. So where patients are going through your system, but for some reason, they've just fallen off the gap of care that they should be on. It could help you spot that and develop a cohort list of patients that you can then reach out to. The opportunity you have when you do that, of course, you develop many things, but more importantly, loyalty. Your patients know that you're looking after them even when they're not within your circle or even when you're not particularly taking care of them at that point in time. Another use case that we're also looking at with Health Insight is around disease, risk of particular diseases appearing for particular patients. And for that, the model runs through the system. It develops a cohort list of patients that you can actually put on a pool, call them regularly, keep them in your circle, but more importantly, help them derive better outcomes for what they're going through at that particular point in time. As I said early on, we do take it very serious that care is moving out of the traditional hospital setting. We're a large hospital provider. I mentioned the example early on about the services that we offer. But if we are not relevant in those new care settings, we won't be relevant in the long term. And so we're investing in the technologies, more importantly, to consolidate hospital data and non-hospital data so we can have the widest view, longitudinal view across the various care settings so that we can then leverage all of the cool technology that we've been talking about over the last couple of days to derive more for our patients. Thank you for listening, and I hope I shared some insight for you. Thank you.